Good afternoon and welcome to the 29th episode of Genomics Gupshup. Genomics Gupshup is an initiative by Mapmygenome to sort of bring in the community of experts, both in and around the medical, the genomics, and others to sort of help simplify concepts of genomics. And we are delighted that today we have a very distinguished personality in the field of pediatrics, Dr. Pritesh Nagar. Welcome to the show. He's the head of the Department of Pediatrics at Care Hospital in Hyderabad, and he has many long lists of accomplishments. So welcome to the show.
Thank you so much for that lovely introduction.
Thank you. And I'm not going to go into too much of the details. We will be going through your little bit of your life's, your background and where you started from. So I think people would like to hear it from you rather than from me. So if we can get started, I think it'll be nice to know, what prompted you to become a doctor in the first place. Was it, lots of family members that were doctors, or you are one of the only in your family, or the first? I don't know anything about, what your background is and what made you become a doctor.
So actually, I am the only medical fraternity in my entire family. In fact, I would say the extended family and probably all my relatives in Hyderabad. So most of us, we are Gujaratis. So most of Gujaratis are basically from the business background. So education somehow takes a backseat in a lot of us. So when I was a kid, actually, I did have a chronic liver problem. And I was on treatment and medications for almost about 8 to 10 years. So, during that time, somehow that, frequent visits to a pediatric clinic and doctor and something that, that triggered and kind of imbibed in me that, probably I would like to do something like this and I would probably become a doctor. It was more about, at that point, of course, we don't really, as a kid, we don't really know much about how the profession is going to be or what kind of social or economic benefits is going to. It was more just about the aura of being a doctor, which caught on. And I was like, okay, if I have to do something right from childhood, I was like, okay, I will probably become a doctor. So that's how it caught on. And probably I never wavered from that. I was very keen right in my school days. Probably I can remember as early as 6th, 7th, I was very keen that I'm going to go into the medical field. So that's how it kind of started off.
Wow, that's very impressive, because I think I had once done a survey of a lot of people, including myself, and what we wanted to be when we were young and what did we end up becoming. And I think the answers were quite, very different. So it's great to see that, something you thought about and actually ended up, that's what you're doing even today. So I think, I must congratulate you. Not many people know where they, what they want to do when they are that young. You obviously have, after that, you decided to be a pediatrician because you said that was what you started off with, being a pediatrician only. But did you, then you went out to get a lot more education? Was that mostly in India, abroad, and I know you've also been training a lot of people as well. I think there have been a long list of people that you train. So is that something that you are excited about in terms of, imparting that education to others as well?
Yeah. So honestly, actually, I never dreamt of or never had the thought of becoming a pediatrician, actually. In fact, during my MBBS days, I always wanted to become an ophthalmologist because that's what fascinated me. But then during my internship, the 1-year training that we have after MBBS, that 1 month of posting in pediatric somehow, changed my mindset, and I got fascinated by this branch. And then that's how I was like, if I'm going to do anything, it's kind of going to be pediatrics or nothing else. So in fact, I still remember that when I had gone for my postgraduate counseling, and my rank was 9th All India in Manipal, and the seats were very limited. So even at 9th rank, I was not very sure whether I would get pediatrics or not. And I still remember calling up my father. We didn't have a mobile phone those days. So I called him up from a PCO and I said, this is the status of pediatric seats. and I would get everything else. But if I'm not getting pediatrics, I'm just dropping and coming back home. I'll write again. But probably fortunately I got it, and that's how the journey started. And yes, teaching somehow has been my passion from the very beginning. In my days in Manipal, we used to teach undergraduate students, and then slowly, probably, I even ended up teaching postgraduate students in my small stint of work there. And then subsequently, when I landed in Hyderabad, I realized that quality teaching is something that is not available so easily. And then, getting yourself updated constantly, getting yourself, imbibed with new knowledge constantly is not something that very easily is available to everybody. So then I realized that I have a real passion for reading and kind of, going through everything new that comes up in the field of what I do. So that somehow percolated into the habits of training and teaching. And, there's another thing that if you read something, you retain a small percentage of it. But then when you try to teach and you try to talk to other people, you retain a lot more about it. So indirectly, it does benefit me also. I also end up learning a lot in that. So that's how it is.
And so when you are, when you are a pediatrician, I think a lot of parents must be bothering you a lot. Because
Yeah,
I think
that's
so. Because it's also many times when people just have babies, I think they really don't know what to do. And so for every little thing, I'm sure that you get a lot of people who come to you for both on the phone, I'm sure, and also I think in the hospital. So, how does, in terms of that, is it that you remember your first 10 years, you mentioned that you were going to a doctor on a regular basis. How is it that you look at patients? Is that something that is, what percentage of patients I think are just overly, they reach out to you when they don't need to come out, but, what percentage are actually severely ill? I'm sure there is some sort of a percentage of people who are the hypochondriacs and people who are worried about their children.
Yeah. So, see, in my practice, so what I have done is over a period of time, compared to, let's say, I would say it's probably my 18 years now of doing my pediatric practice. So the first decade versus now, that is in the last 5-7 years, I have kind of, learned to let go, and at times probably even say no. In the earlier days, it was like, every single call I used to attend, and I was like, okay, 10 o'clock, 11 o'clock in the night, you have an emergency, come down to the hospital. I'm right next door, I'll come and see you, and that kind of thing. But then it realized over a period of time, it takes a toll on your health. You end up spending a lot of sleepless nights, unhappy family. And so in the end, I decided to let go. So, and most of my regular patients are tuned to things, at least those who have been coming to me for last so many years, now know very well when they need to worry, what is panic, and when routine problems, which do trouble the kids, but then having interacted with me so many times, or even the newer parents who come, I keep telling them. So then they know what is exactly the situation where they would need to panic, and what is the situation where it's kind of a routine problem. They could always wait for the next day and come over. But yes, having said all that, taking care of kids is not a very easy job. And to be honest, on a lighter side, I would say that we are something like glorified veterinary doctors, because smaller kids probably, which form the majority of our population of patients who come to us, once they get older, they don't fall sick. So the younger kids who come, they can't express themselves, they can't really tell what's happening to them. So it's all about visual cues, seeing them, trying to understand them, and then trying to come out with a diagnosis. So in that situation, we do rely a lot on parents. And because parents are also in their phase of early parenthood, you see a teenager or an older child's mom or dad versus the mom or dad of a newly born or a baby who is 1-2 year old, they would always be more apprehensive and more worried and more panicked. Even one sneeze or one cold, they would start getting panicked and rush. And the same thing, it's a teenager who coughs for 4-5 days, they would say, chalta hai, ye to abhi ho raha hai, kuch problem nahi, kind of. So that's there. But I think the basic crux of all this is, the more you educate and empower your parents, things become really easy. That's what I've realized over a period of time. So actually my emergency phone calls and all that have actually dropped over a period of years. They were a lot more when I was less busy. They are a lot lesser now when I'm more busy.
That's great. You've been able to streamline that, and I like that point where you say that a lot younger children are basically unable to express their feelings, and but you are also, I think, in some ways become part parent when you are when you look at the children as well, right? Because you have to look at those cues and be able to answer and figure out what is going on. But if you just look at the overall situation in India, do you think do we have like challenges in pediatric and neonatal care? Because clearly we are going through a lot of changes in this whole field as well, right? I mean, people initially didn't have as many tools, but today some people have the tools, others don't have the tools. Whether it is in terms of screening newborns or otherwise. So, what are your thoughts around that?
So the challenges are there, and probably we as a nation, till this is my thought, that till we are able to develop a very robust public healthcare system, something like what the UK has, or probably Australia has, or maybe even New Zealand, I believe. So
Canada.
till then the challenges are always going to be there, because the majority of healthcare, whether it's pediatric or any other thing in India, is driven by the private market. So what happens, or what my observation is, cost and quality, these two somehow don't go hand in hand. And that's where the biggest challenge comes. And hota kya hai, in case of children, it always is the general assumption of public, it's a small baby. So it's a small baby, why the cost is so much? In fact, it's reverse. It's a small baby, that's why the cost jumps up. You have the equipment, or for that matter the skills required, or for that matter anything that you do is a lot more expensive when you treat a small baby. That's a simple analogy I can give to this is, let's say you buy a laptop. It might cost, let's say a basic laptop might cost 40,000-50,000 or something, a lakh. But you buy a PC, which is a bigger unit, you get it for a much cheaper price. So, it's the same thing applies there. It's not a very good analogy, but it's something that can be understood. So the cost is one thing which always becomes a very big burden in case of pediatric population. That's one big challenge I see. And so far, honestly, I am not able to see any kind of easy outcome or easy solution to this. Though nowadays we do have a lot of crowdfunding and all those things, but till insurance is something which universally everybody adapts. That's a big challenge. The second thing is, sitting in a city, working in a corporate hospital, it's very easy for me to say that, okay, we can do everything, whatever you want, you can get your child, kind of a thing. But the same thing for a pediatrician practicing in, let's say, a smaller city or a town or a village is very difficult, because they wouldn't have that many facilities or that many, infrastructure to, take care of all the basic needs. So the basic grassroots level pediatrics, or for that matter, again, this applies to other field also, is something that needs to really become a lot more robust and strengthened. And that probably requires, so many things. It requires education, it requires training, it requires empowering them, it requires the right kind of guidance and tools. So those are all challenges and troubles that we keep seeing. But yes, compared to what was, let's say, a decade or 2 decades ago, and compared to now what is there, we are probably doing as much as probably the West is doing. And probably, yes, we are doing for a far more lesser cost than what it would be in the West. But then all those people who always say this, that the cost is so less in India, even in the, let's say, biggest corporate places, the cost is so less in India compared to the West. What we need to understand is the per capita income of India. So when you look at that versus the cost, the gap is really huge. So that's something that needs to be closed in. But then again, here, I would say that probably 2% of patients of the entire population of sick patients who may come to you would actually require that kind of high-end care. That means the 98% of patients can be sorted out by even a basic amount of decent pediatric care. So I just would love to see the development of some kind of cost-effective but quality pediatric care. that's something I would look at as my dream.
I think that's amazing, right? When you think about it, that you need high quality care in only 2% of the patient. I mean, very expensive or high quality or whatever you may call it. And maybe if there's a way to sort of do that, and I think now we have started to see, for instance, a lot of tools that are people are doing, where they are looking at even MRIs and other things, from a distance and things like that. Or even operating them. So I think maybe they will get to that stage where we will be able to provide this to every hospital, hopefully. But do you think, for instance, like I don't know exactly how many babies are born per year, but I remember it used to be around 26 to 30 million is what I'm assuming, somewhere in that range, right? And I know that the number of people who went through, number of babies that used to go through a screening, like a newborn screen or something, was less than 2%, right? So is that something that is improving currently in the country? And two is, has that even made a difference? I think that is also a thing, that when you're doing a basic newborn screen like the UK does, will that have a big effect in terms of when you're looking at like 98%, can we screen out these, at least look at the babies that need attention upfront, rather than, either delay that diagnosis or otherwise? Do you think that role of newborn screening has, it has some role to play if we are able to figure out how do we filter this out over the next few years?
Yes. So I am a very staunch believer of newborn screening. And to just put it to facts, my son is 14 years old. And 14 years back, when this was still a very nascent thing, I did a newborn screening for my son. So I am a very staunch believer of that, because there are so many disorders, the metabolic disorders for which the newborn screening does detect, which could be picked up. And quite a few percentage of them are amenable to some sort of early intervention. So we are basically looking at some sort of preventive therapy or some sort of early salvage therapy before the problem becomes to such an extent that then you can't do anything and the child loses his childhood, or probably even, because that's the biggest problem when we are dealing with children. The same thing compared to adult. Let's say someone is dealing with a 30-40-year-old. The life ahead is another 20 or 30 or 40 years. But then when you look at a newborn, you're looking at the next 70 years. So that's why these things become important. Now, has it changed? Yes, but I am not very good with math, so I really don't know the India figures. But I would say my own personal experience compared to before and now. So some things are slowly getting accepted. For example, at my center now in care, we have 100% screening for hypothyroidism. Probably in my previous hospital, I would say just about 5 years ago, it was hardly about, I would say 50-60%. So now I am able to screen 100% of babies born at my place for hypothyroidism, which is at least a start. And I would say at least 70 to 80% of babies who come to us here do undergo the hearing screening. So it's another bonus point. Moving to the extended newborn screening. Now, again, the problem there that comes in is the pricing. The cost is something that becomes a hindrance for a majority of population. Those who are in the affordable category, those who are in the elite category, they would always do it, and there are parents who are accepting it and doing it also. But then the majority or the bulk of population doesn't fall into that category. So that group of parents are someone who don't readily accept it for the reasons of cost. So that's something that sometimes becomes a hindrance, but still the acceptance is definitely going up. But what I would give a message is, if not anything, at least hypothyroidism and hearing, two things that probably is not costly, is something that should be universally implemented. And I'm seeing a lot of hospitals are also doing it. Even smaller centers have started doing it. And it's really, really useful. Hearing is something which I realized how important it is, though I was a believer of it, but I realized the real importance when I came to care. So we have a cochlear transplant team here. And I keep seeing on an average 3 or 4 babies who come to me pre-cochlear transplant checkup and vaccination and everything. And they're all congenital deafness children. like 5-year-old child, 7-year-old child who is not able to hear, and because they are not able to hear, he is not able to speak. Now, had this child undergone a newborn hearing screening, he would have undergone therapy earlier. Not that it would have changed the course of the disease, but instead of waiting till 7 years, he would have got a hearing aid at an early age. By now, he would be speaking and communicating. So it's very sad to see those parents and kids struggling. So, that is how you would look at the newborn screening preventing problems. The same thing applies to hypothyroidism. I still remember the parents still me. I know the name of the child also, but I don't want to just put out on a forum like this. But this child came to me at 3 months of age with all full-blown symptoms of hypothyroidism. And unfortunately, nobody had really looked into it or picked up. The baby never underwent newborn screening. 3 months of age, we picked up a hypothyroidism. Of course, the treatment was done, all that. But then that 3 month is lost. And when it comes to problems like this, time is brain. So the 3 months of lost time of brain development is never going to come back even in the next 30 years of life. This could have been prevented. So we probably, I would say in last 1 year, we have picked up about 2 or 3 hypothyroidisms, congenital. So yes, we must have screened hundreds, but we have picked up 2 or 3. But that means those 2 or 3 are now saved from a lifelong damage. That's the whole idea.
Yeah, and I think, those are some very fantastic examples, because I think for many people, they don't realize that it's not about the, one, if we can implement it for everyone, I think that's the best. But even otherwise, I think the cost that the parents and the family and everybody else bears later can be much more harder, right? Like you mentioned about the child who couldn't speak. I think, most people don't understand why why they're behind in their studies or otherwise. And I think if you don't screen, you don't find it, and therefore are unable to help them in some ways.
Just to add to this, hearing is something which still, though many are accepting, I'm still finding a bit challenge at times, because a lot of parents, who have come little late, 1-2 months, they're like, "Nahi, when we speak or when we make noise, the child is able to respond." I said that is not what it means. And don't go by that. That's something that probably our mindset needs to change, and we all need to push. Probably, if I remember right, I'm not very sure at this point, but I remember reading it once upon a time. There was some recommendation even from the government about probably trying to push for a universal hearing screening. So that's something that probably has to get implemented across probably even smaller centers and everywhere.
So I don't know if you've heard about the Nidan Kendras that started, that the government has started. So these are basically done. They're not that. They're still about, I would say, about 30. They're a decent number. It is there in every state, and the idea was that when you look at things like thalassemia and many of these other genetic conditions, that the government would actually screen these babies for free in these Nidan Kendras, right? So the idea was to get to a universal screening stage where you're talking about whether it is hearing, hypothyroidism, but also things like you're looking at phenylketonuria or G6PD or thalassemia and others. And I think if we can, if we can implement something across the country, I think maybe we'll see many more children that can be saved, and not have to go through the trauma of the disease, especially if it can be prevented.
I think Goa has that policy of universal screening. That's something which is commendable.
And I think many other states are also looking at doing something. But the one I was talking about was more from the Department of Biotechnology. They wanted to create that awareness and build, understanding of these kind of genetic problems.
Absolutely.
Okay. So the other thing that I have seen often, and I know that some of my own team members have brought about to me, is that when they are for children, I think we have started to see either report a lot more of sepsis cases and others. Do you think that is actually rising, or it is just that we are hearing more about it? Because they can be two separate things in terms of what is going on.
So again, I'm not very sure of what the data says currently from India, probably across the world. But what I have seen in my experiences is probably there are two aspects to this. One is we probably are picking up more cases because probably more of them are aware of requirement of healthcare services and they are landing up at hospitals. So there would be a certain population in this who would have otherwise probably not landed up at hospital, especially those from the poor socioeconomic strata or the rural areas who are now coming to healthcare, who probably would have, like, I remember seeing a lot of kids in my very old days who would be brought dead, kind of a thing. So that population is decreasing, so probably there are a group of patients who are contributing to that. The second thing is, this is probably one of my favorite topics of discussion, and that is, one is the indiscriminate use of antibiotics. That's something which probably leads to a lot of these kind of problems, because then the bugs become resistant, and then eventually even the normal flora. See, we have to understand that our body is not living in isolation. So in fact, our human body, across your nose, your throat, your skin, everywhere there are microbes, there are bacteria. They are staying harmoniously with your body. They're not doing any harm to your body. But then when you disturb that standardized or that kind of harmony between the organism and this one, these can then invade your body. And one of the contributing factor is actually the indiscriminate use of antibiotics for simple things, which then, I always tell parents, and I always remember the story, if we all recall, that the boy who shouted wolf, wolf every time, and when the real wolf came, nobody came to help. Because so it's like you give antibiotics and antibiotics every time for every small thing, and then you have a real genuine problem. The bugs are resistant, it doesn't work, and those kids land up with real bad problems. So the contributory factors are multifactorial. It could be that more people are reaching the healthcare. There's more availability of and use of things which should not be. Probably we as the medical fraternity should change the way we practice. That I feel will bring down the number of cases and probably, yes, get them better care.
So I think you touched upon something that's right now very much current in my brain, because we are currently developing a microbiome test, right? And I've done mine 3 times over the last few months. And it's fascinating because one thing that my parents didn't let us do was to use antibiotics in the beginning, right? So if we were never given much of antibiotics. At least I don't remember any actually till I grew up. And maybe I don't remember in certain cases, but that was not the standard of care, at least not in where I was. But that's not true in the case of my husband's family, actually full of doctors. I think they got more antibiotics than I ever did. But one of the things we were looking at was to see what is going on with our microbiome, right? So when you mentioned the bacteria and all of the other fungi and other organisms that live in our body, it was fascinating for me because I did it 3-4 times. I did it once post Diwali, then I did once around November, then I did once in January, right? And December, and then once in January, and I'll probably do one again. So I wanted to see the effect of food, the effect of travel, stress, and also I think antibiotics, because I did take some antibiotics around, when I was in Doha. So it was fascinating with writing down all of the things that I'm eating and seeing if it is having a change. And it does have, it is making, actually, it wipes out certain types of bacteria. You can see some other develop and so on. So I think, while we can, this is a science that is, not yet fully out there for everybody, but it is something that I think that hopefully people will start to see what is actually happening and not just say that, doctors told me not to take it, but I'm still take it because it makes me feel good now. Immediately it makes my child feel good today, right? And they want to stop all of their problems like right now. I think people have to start seeing what happens, consequence of that to the rest of your health, and what you're doing to spoil spoil your own microbiome in that sense. But hopefully I'll write a little bit about this so that people can get a sense of, my own experiences with understanding of my little organisms in
Exactly.
my gut and other places. So, yeah.
So just to add to this, because you brought the entire topic of microbiome. If you really look at it, babies who have been breastfed versus babies who are kind of on formula feeding or top feeding and all that, the entire gut microbiome is different. And the gut microbiome of babies who are on exclusive mother feeding is so much different that it keeps them healthy for a longer time. It prevents so many illnesses, not only immediate infancy period, but also later on in life. In fact, there have been anecdotal literature about relationship to obesity, future cardiac problems, future dyslipidemia, and so many things. So so much of things are going on inside that microbiome that we still really haven't found the tip of the iceberg.
I think I agree with you. I think there are many, studies that are there, and I think now with the microbiome studies, I think it will be obvious to parents, and it will make your, case that pediatricians have been making for a long time. But I think it will make it a lot more stronger now with more scientific evidence in terms of what is happening with the microbiome. So, you're currently, I think one more thing I want to go upon is, you're the head of pediatrics, and I'm sure you have a whole team. And one of the big challenges of having like a large team of doctors is, is there, does it, and especially in the field of medicine, right? People go to a specific doctor. They'll say, I want to go to Dr. Nagar, or I want to go to, someone else. So how is there a way to bring a more standardized process? For instance, if you want to bring something, one is, of course, you can standardize testing processes, but how do you standardize other things? Like, are there ways of bringing in, especially since you are an educator also, is quality something that can be taught? Is there SOPs that can be taught? And does that mean that people will still come to the doctor that they trust and can trust be created? It's a very long, difficult question, but would love to get your thoughts on it.
So there are multiple facets to this question. So the first facet is about a particular doctor and this one. So it's a bit difficult to get that working out in India, is what I have found, because once a patient or a parent is used to your style of talking or your style of treating or dealing with the problem, there would be always a certain subsector of patient who would always like to come to that particular doctor only. So that probably is something which may not always change. But what I am trying to actually work on it here in this department here is like every parent who comes here, like our way of saying is we work as a team. So it doesn't matter to whom you show in the team. We will be giving you the same kind of care or same kind of treatment. Having said that, it's very easy to say, it's very easy to put it on paper, but when it comes to practice, it becomes a bit difficult, because everybody comes from a different background. Everybody has come from a different education system, though we talk about the same basic subjects and build up to pediatrician, but the kind of education that has come is always different. So your thought process would always vary. The way you treat would definitely vary from person. Even if there is a standardized protocol, the thought process would definitely vary. So that is something that probably may not happen so easily, like probably it's there in some Western countries. But I do see a way with more and more group practices coming up that this can be the way. That is one aspect. The second thing is about quality. Yes, that's something that is paramount importance, especially in hospital, inpatient care, and when you're taking care of sick kids. So the way probably quality in pediatric is something that is a bit more challenging, because getting trained manpower, it's not just about doctors. So, I always say that the biggest strength of your department is not your doctors, it's your nursing staff, because they are the ones who are always there at the bedside. They are the ones who are taking care of things on day-to-day basis. So a strong nursing staff, and that's where the highest attrition is. And that's where in that sector where we are actually having a real dearth of trained, unlike the Western countries. So that is something that really needs to improve. So most of us, probably you ask any pediatrician or anybody running, most of us, how it works is we have a fresh nurse or someone who has joined kachi mitti ke vaisa. Then we mold them, we shape them to the unit, we train them, and some of them do really, they're all hard workers. That's one beauty of the nursing staff you see in India. They're real hard workers. They won't flinch even if you say something to them. That's a beauty that you won't find anywhere else. And they get molded, and then it boils down to, they are underpaid. So they jump and they get better pays in Middle East or abroad. So that kind of a thing always keeps on, disturbing the harmony of the system. But still, if you are able to hold on to your basic this one, yes. And the third part of it is SOPs. Yeah, so SOPs always help. In fact, SOPs should be there for probably every kind of treatment or procedure or anything that you're doing in your hospital or in the unit. Again, very easy to say, very difficult to implement it, but slowly and steadily we are getting there. In fact, if you look at the concept of NABH, which has been there now and it's being made mandatory, one of the ideas behind that is to have a SOP across your healthcare system. So similarly, you can have SOP across your treatment or across your care protocols. Now, for example, let's say I have a patient with, let's say, XYZ or an asthma problem. Let's say I'm just picking an example. So there should be a standard SOP, whether I am there, whether a team member there, or probably whether a nurse is there. They know that, okay, this is the protocol, you follow this. So once that happens, once you implement that, and then that SOP starts percolating. Now what happens is most of the places, the SOPs remain to the purview of most of the times intensive care units. But I would look at those SOPs percolating to the wards and an outpatient care. So once a standardized protocol comes, like child comes with respiratory infection, it's a viral. This is the standard protocol, whether Dr. Nagar treats, whether someone else treats, or whether anybody else treats. This is the protocol. This should not change. Not because you feel that you should add something, not because you want to make the parent comfortable, or that you're afraid and you want to add an antibiotic, or you're afraid you want to add a nebulization. So that, rather than that, this is the standard protocol. This is the margin of deviation which is allowed, and everybody follows this. That becomes standardized, which is still a long way I see, but if that becomes, then probably it will not matter as to whether I see or someone sees, because the parent knows that he's going to get the same treatment. And I would just wish that that kind of a thing comes.
So one more thing, and I know we do this, for instance, we have a group of genetic counselors, and when we have a difficult case, for instance, then they bring it up, like just like a tumor board does, right? I mean, where you have a specific case, you would like to get inputs from your peers. Is that something that also happens in the pediatric space, where you find the child with a diagnosis that's hard to understand? Is there like a tumor board, like sort of, or like we do a genetic counseling huddle, or whatever you want to call it, to figure out, is there like, are these standard meetings on a regular basis, or that doesn't happen on?
So I'm not very sure of other hospitals, but to be very frank, and sadly, no, we don't have that. But we do what, have our own internal kind of huddle or something, sit together, discuss out, and jot it down, and this is ruled out, this is ruled in, this is the right thing, wrong thing, and then we kind of come to a conclusion as what to go about. And then outside the hospital purview, I have my own close group of pediatric friends from different places. So there have been a lot of times when we have something challenging here and I'm not seeing a way out. I have phone has made life easy. So I have a huddle with them over phone and we discuss and jot out. And then sometimes what happens when one person hits a roadblock, the other person probably might open up a new door for you. So that happens a lot of times, and that has happened. So I just wish I could show you. We recently did this kind of hurdle for a doctor's child who had a lot of trouble in getting up appropriate diagnosis. And then we all just sat down. And I still remember I took a chart and I said, okay, this is the thing. First point, this is possible, likely. We have done this. So this is kind of, so we made a big chart and we then finally zeroed down saying, okay, this is what is remaining. Let's go in that direction. So those kind of things.
So let's move to genetics and do you see any cases? And I'm sure you do, but I know you do. But what kind of cases do you see normally where people are coming to you, where the cause is genetic or their cause may be genetic? Do you see a large percentage? I know that a lot. We discussed that a large number of people might come to you even when their child is not, is coughing or things like that. But in some cases, people do come for a genetic reason. So what kind of approximately what kind of diseases these are, and do they come on time, or is that something that could have been prevented if they came to you earlier? There are many questions in that.
Yes. So yeah, I do see. I have a bit of passion for metabolic disorders. A little bit of I have a lot of interest in immunodeficiencies and all that. So I do keep seeing a lot of these kind of cases, and over the period of years, yes, I've seen a lot of genetic problems, a lot of rare diseases, and all those things. And it's been a huge plethora of cases involving different systems, right from things related to immunity, CNS issues, immunodeficiencies, cystic fibrosis, neuromuscular disorders. So it has been a mixed bag of all these kind of variety of cases that we have seen. And sadly, in my experience, most of the times that I have seen, they've come at a stage where, kind of, they are not amenable much to any kind of treatment or therapy. And that is kind of a bit sad. But having said that, from what I know basic of these genetic things, see about 70 to 80% of these problems are usually seen in children, all these genetic problems. Because when there is a defect, it starts manifesting from childhood period. So children actually contribute to a majority of subset of patients who are having genetic problems. So that's how we pediatricians keep seeing them a lot. Now, from what I know literature, there's no standard definition of these rare genetic disorders, but overall, if you take them as a bag of all the genetic disorders pooled together, currently treatment is available only for less than 5 to 10% of cases. And remaining of them, most of the time, it's more of palliative care. And even in those 5 to 10% cases where the treatment is kind of available, there are so many situations where the treatment is beyond the reach of, forget a common man, probably even a fairly well-to-do person. So that is something which challenges, but probably as time goes on, hopefully this will change, and whatever is available treatment also probably might become more and more affordable. What else is this? Yeah, so I was just trying to say in the same matter, I was just recalling one patient. He was a 15-year-old boy. So when he came to me, and in fact, this was the first interaction, this case with Mapmygenome. That's how I remember this child very well. So this child was a 15-year-old boy, and he had come to me from Maharashtra. And he had been roaming around almost for the last 5 years. And he had no diagnosis. He was a child who basically was fairly okay. But once he reached 7, 8 years, he stopped walking. And then he slowly, by the time he came to me, he was wheelchair bound. So the commonest thing that comes in anybody's mind in this situation is always the Duchenne muscular dystrophy. That's what is a more common thing. He was worked up for Duchenne by 2 different people twice. It was negative. The thing is, that's where probably the training and knowledge of genetic or of an idea that things can be done beyond that would be helpful kind of a thing. So this child, we went ahead with the investigation, and we picked up to be a spinal muscular atrophy. And the thing is now, time is lost. Child is already wheelchair bound. So there's very little we can do. The second thing, we do have some innovative therapies available nowadays. The drug costs about 2 CR a year. Now, 2 CR a year is something which is beyond the reach of almost anybody unless you're Ambani or Tata. So, so those are kind of challenges that we see. I always see. But then there are situations where it does help also. I'm just trying to talk in more of terms of examples because that's how I relate to. So I had a family who used to come from Nizamabad. The first child they came to me at about 3-4 years of age, and this was about a decade ago. And this child came to me with cardiorespiratory failure, and the child was with us in ICU for quite a few days. And finally, we couldn't figure out a cause. The only thing we knew was he had a very bad pulmonary hypertension, and we didn't know why we had. We did all possible investigations that we could do, and at that time, these genetics were not easily available also. So we didn't figure a cause, and that child finally actually died. Then about 4 years or 5 years ago, they came with a second child, and this child was about a year old with similar problem. And the parents had already lost hope. The child came again in a bad shape. This child, I was somehow able to convince them that you go for a genetic testing. They were very much hesitant, but finally they agreed. We picked up a particular mutation, which is known to cause pulmonary vascular fibrosis, leading to irreversible hypertension. And it's non-treatable condition. Now, with that information in background, the parents have now gone for the next pregnancy, and we are doing the antenatal workup. So I'm looking at giving them a healthy child. Let's say if this child is affected, rather than going through all the trauma and suffering, they could always opt for a next child. So we're looking at, it's not only about diagnosis at that point of time, it's also about how good you can offer them a future child. That's something that becomes very, very important in these kind of scenarios. So even I remember another case like this. We had one mucolipidosis whom we died. That was the first clinical exome I did when it was costing about ₹1,00,000. And that's about almost 10-12 years ago. And that child, we picked up mucolipidosis on an exome. We had no other way of diagnosing this clinically. Though we read in books, this is the feature, that is the feature, you can't make a definitive diagnosis. So we made a diagnosis based on an exome. We offered, and that child unfortunately lost because there's no kind of, and that child, second pregnancy, antenatal diagnosis, the child again had the same problem. They aborted. The third child, no mutation, the child is healthy and doing well. So this is something that we need to look at in child, and that is something we can offer only in a pediatric population. That's the beauty and joy of it.
Absolutely. I mean, and I think, like you mentioned, most of these cases, I think they had one child who was affected, and then they came to you. I mean, it would have been okay if they actually did the exomes for the parents upfront and done before they got married even. I think, but I think that's a little bit too much to ask for especially. But we can do a carrier screening upfront and see if there is something that can be passed on or otherwise. But I feel that now that we are, our genetic counselor will be available at care. She's available, I think, mostly on Wednesdays or something. I'm not sure exact time right now, but I think, hopefully it is not just the pediatric doctors, but also maybe the gynecologists and others where people are coming to for a checkup. I think at that point of time, if their family history is well captured, I think a genetic test can help. And one more point I wanted to bring about was that, there are also lots of these communities, right? So, there are many rare diseases, but there are communities like, the Genetic Alliance and others. And, we constantly work with them. It's to say that, the problem is right now, many of them are called, have very few known cases. That's because most of the time they're not getting diagnosed. So if we actually could diagnose more, the community becomes larger. And when the community becomes larger, I think the possibility of a drug or a therapy also becomes bigger. But I think that's another reason why we need to look at finding these cases, because, it is not just for that particular family. I think it's also for future families to be able to understand those diseases.
Absolutely.
So I know I can continue talking about this, for a long time. But when we think about just overall, from your point of view, what do you think prevention means, right? Because different people think prevention differently. So what are your thoughts on prevention?
So prevention as in general, or prevention with
anything, prevention of disease or prevention of, in this specific context for pediatric, for parents, right? I mean, how do you prevent disease for children? Your thoughts on it? It can be anything, whatever you feel like.
It's a very tricky question and a bit difficult to answer. Let me try. So prevention for me, what I would look at is, if you are able to have a healthy, in the sense you're not suffering from any kind of major disease, and you are able to go through your routine without any issues. If you're able to achieve that, whether it's a child or whether it's an adult, probably you have achieved a majority of the subsect of what you called as prevention. So it would start right from the habits that you cultivate, be it the physical activity, be it your eating habits, or maybe when I talk to parents. In fact, a lot of parents do at times are scared when I give them a lecture on breastfeeding. I'm a staunch believer of that. So that's a preventive therapy. You're preventing in so many problems. So that is one thing. Prevention also probably will be in terms of how you educate your child, or the kind of habits you cultivate into your child, whether it's in terms of just this stupid device which is ruined cause problems of so many things. So that starts now. I'm seeing kids.
And you write on the prescription, no phones.
So I'm seeing kids 10 months, 11 months, they keep swiping that. So you don't give them that. That's prevention. So what else I would add into this?
I think that's a fantastic, great thing to talk about, because I think a lot of us don't realize it, that, it's an easy way for parents to sort of give a device because it frees up their time. But I think then they get addicted to the screen. Yeah.
So it's related to so many problems. And really, scientifically speaking, the science behind it is, when you are addicted to a phone, the reason the addiction happens is you're doing what you like, and the result you get is kind of a positive biofeedback.
Mm-hmm.
That positive feedback is so staunch that you feel like you keep on doing that. And it's an endless plethora of options there. But then, if you really look into that, has led to so many problems. Kids with poor cognition, autism is on the rise. We really don't know whether it's. I have never seen so many autism cases as I'm seeing now. In my pediatric days, autism, obesity, तो Western countries में होता है, हमारे पास है नहीं. We never used to even bother reading it, and now it's rampant.
Mm-hmm.
So again, these are preventable things. What our lifestyles are somehow pushing our kids to that edge of those kind of disorders.
So when it comes to autism, I mean, I guess we don't know all the reasons, but part of it is also could be genetic.
Yes.
And do you see that? Do you see a more increased number of cases where you're, finding autism as something and identifying the root cause of where that comes from, or that is?
I would love to do that, but to be very honest, I don't deal with them. The reason being is it's a completely different domain and requires a lot of insight and input from a person who's specially doing that. So that's something which I don't really deal with it. But yes, if you ask me, really, I would look at screening all these kids, because definitely there is a component of genetic there sitting. It's something like a two-hit. You have some component, the environment triggers the thing, and the entire thing blows up and manifests.
Do you? I'm sure you do, but what are the common myths that normally you have to fight against, if I may say so?
So the biggest myth: mother is eating something, and does it affect the baby because the baby is feeding? So mother is like, the grandmother or the father or someone will say, इस mother ने आइसक्रीम खाया है इसलिए बच्चे को सर्दी हो गई. Yeah, mother had something outside yesterday food, that's why baby is having loose motions. So that's a big myth. And honestly, I always tell them this, very, very innovative, my idea of answer I give them. I ask everybody, what milk you drink. And they all say cow's milk or buffalo milk or whatever. So I say, did you go and check what did the cow eat? Because you're drinking the cow's milk. And did you correlate anything happening to you because of what the cow is eating? And, so that is one common myth. And then this is another common myth that is there quite commonly in India, more often. And it's about hot foods and cold foods. So this food will cause, ye thandak karega, to ye nahi dena hai, ye garmi karega, to ye nahi dena hai. No, there's no such thing. There's no such thing.
It's not like a generic किसी को गरम करेगा और
ऐसा नहीं होता है.
But
I don't know really. If you trigger some point, I can remember more of myths.
But I mean, I think, but different foods do trigger for different people, right? I mean, in terms of what they eat and others, mostly based on their metabolism.
That's a different, but altogether
different class of
like maybe intolerant to certain foods. That's possible.
Yeah. So I think one of the things we found quite often is when we do like a genome patri or others is that we look at a lot of these food allergies, right? Like so peanut, lactose, and all of that. Now, one of the things I found is that in Western countries, we find a lot more peanut allergies as compared to India.
Yes.
I haven't seen a genetic analysis of that yet in terms of what percentage. But do you think that is because of our, maybe is it our microbiome and the environment we are in, or is it just that, maybe we are, but we don't care and we continue eating it, and then later on that develops? Because we do see that for a lot of people, especially lactose, we are seeing that happen, when they are in the 50s, then you start developing some of these symptoms. But I don't know if there's an answer for that in terms of...
I don't know. I'm lactose intolerant.
I think what someone told me was that if Indians stop drinking milk, a lot of our problems will go away.
Actually, that's true, Actually, that's really, really true fact. Probably a lot of people may not agree with me. This is kind of more of my personal thought, but it's based on facts of what I am looking at. So this is how I think that, that milk production by a cow or a buffalo or whatever animal, the animal is not producing that milk for us to consume. We are consuming it. That's a different story. It's producing it for its calf.
Yes.
But we consume. And there is some amount of fact, though I may say it's not conclusively proven, about milk being the, janam data of so many problems. Right from allergies to a lot of gut disorders and all those things, it is a significant contributor to it, especially animal milk.
Yeah. So, I stopped drinking. I mean, I can drink it. I don't have a problem with it, but I don't drink normally. I don't have milk in my coffee or tea. I don't have sugar. I have cut out a lot of things for many years.
That's very healthy living.
Yeah, but many people tell me, sugar to hai nahi, why are you doing this? And I said, I want to continue being in that state. I don't want to
That's nice.
Get to that point where I have to, told that don't do it, right? But I think that's the... So is there anything else you would like to say? Then I have this rapid fire round that I want to ask you. But before that, if there's something that and I know I can continue this conversation for 2 hours, but I would not like to take up so much of your time today.
No, it was fun talking to you.
If there's anything you want to say, otherwise I'll move to the rapid fire.
Sure.
Okay. All right. So, are you a morning person or a night person?
Night person.
Night person.
I can't wake up in the morning.
Same as you. So, if you were not a doctor, what would you have been?
So I'm good with maths, and honestly, maths and finance. So I would have definitely gone into something with finance, whether it's into
Gujarati genes. Yes.
Huh?
You said Gujarati genes.
But I don't have the business genes of Gujarati. So I would have gone more on the finance lines. Yes, but that would have been something which, in fact, that was my backup plan if I don't get into MBBS.
Okay. And what is the most common complaint about you by your friends?
Well, most of my friends are from the same community, doctors, so they don't have complaints because they are in the same boat.
Yeah.
But my non-medical friends and cousins, everybody, the complaint is I'm never available for them to give child.
Oh. And which is your favorite vacation spot?
In terms of location, it would always be a beach. And in terms of place, it is the Andaman Islands.
Wow, nice. So actually, in one of our Gupshup sessions with Dr. Tangraj, and maybe it will be of interest to you then, because he's done a lot of research on Andaman population. So it's very fascinating, more on the heritage and where we came from. And he found that Andamani's population to be a very interesting set of people, because they also shared a lot of genes with the African people. So in terms of migration, there was one small sect of people that moved here, and they have a very close genetic link over there. So more of one of the earlier set of human beings that came over there. So just thought maybe since it is an interesting, location for you, maybe that might be something that you might want to, listen to and talk to him as well. All right. So I think I had an absolutely fantastic time talking to you. It's a pleasure to have been able to spend this time talking to you and having this gupshup. Is there anything that you would like to tell our viewers, patients, parents, or whoever else is watching this?
Yeah, so the best thing would be, so the best message that I would give is probably that's my philosophy of life is one, learn to let go, because life is too short to keep too many sad moments or too many petty things to ponder over. There's always a better tomorrow coming. And I would always look at living life or living your day as if, there's a very nice saying. I don't recall who had said, but that's what I would say. Live as if there's no tomorrow and learn as if there's an endless tomorrow.
Wow, that's amazing. Yeah. That I think those are absolutely.
So if you actually look at my WhatsApp status, it's not changed for last almost 8-10 years. It says that live life the fullest. Diapitas should say no regrets.
No regrets. Yes, absolutely. But thank you. I think that those are great things to close this genomics gupshup with. And thank you once again for taking the time. I hope to meet you in person soon.
Definitely.
Thank you.
Thank you.